You all, and it's great to be here to discuss the new metrics that just came out recently. I wanted to start out by saying, thanks Bob for that inspirational talk. I think he laid out some really big challenges for us. Many of the Steve and I and other colleagues, we do interviews around the country of health systems trying to make these investments in social determinants, and one of the key challenges, I think, that's obvious elephant in the room here is the investments take quite a long time to see benefit investing in these education, social determinants. And one of the realities of our healthcare system is that we see a lot of churn among payers. And so one of the challenges here is how do we commit to addressing these social determinants while we know that patients may go to other payers and we may not see those benefits accrue to ourselves as a health plan. So there is a real structural problem that we're dealing with here, and there needs to be some change in that with respect to that issue, I think, if we're going to move forward. That said, I think one of the key challenges here is that the intermediate outcome measures are the most vetted measures. They might not predict mortality in the long run, but have been shown to reduce exacerbations of diabetes and chronic illness, which may have benefit to quality of life rather than longevity. So even though we may not see mortality benefits, it's the best we've got, and that's what I'm going to show you today. So today we're going to focus on blood pressure control, common HEDIS measures, both for adults, all adults, and for diabetic patients. Going to look at A1C control, both the amount of testing that's done, as well as A1C control for diabetic patients. We're going to actually also look at persistence of beta blocker after heart attack, as well as medical attention for nephropathy for diabetics, as well as eye exams for diabetics. I wanted to orient everybody to a packet in their what I'm going to review in your packet. It's this page that starts with the blue headers on top, and it should be stapled together. Here are all the performance metrics that I'll be reviewing, so no need to scurry and write down performance scores or anything like that. You have them at your fingertips. So we'll start with the controlling high blood pressure among all patients. And I'd like to call out a few things as we kind of go through each slide. The first is So as you can see here, in controlling high blood pressure, the national 90th percentile, or what we judge ourselves against in California is the 90th percentile for national performance, and that's at 76% of all patients with blood pressure control. We can see that California as a whole, we're definitely not meeting that 90th percentile mark at 63. We do see, though, within California, many groups nearing towards or at or above the 90th percentile, and these are Kaisers of Northern and Southern California, Sharp, as well as Western Health Advantage. All of these groups are they have more control. These medical over the physicians in the group. They're more singular relationships. That may be easier for them to influence guidelines. As you can see here, Cigna, Aetna, and others that sort of have these network approaches continue to be at the bottom of performance in our state. And we can see the national top 10 if we kind of look outside of California and see who's doing the best in the country. We can see that Kaisers, through their medication bundle, have risen to the top of performance nationally. But we can see here other plans in Massachusetts, Wisconsin, etc. here. And we also wanted to point out that the Blues here in Wisconsin actually do achieve top performance. So we can see that the Blues in California are not quite at that level, at 61% compared to 78%. In terms of diabetic blood pressure control, we can see that the 90th percentile grade A performance is at 78, and California average is below that at 67. Again, we see the same pattern of blood pressure control among diabetics, again with these four Kaiser North, Kaiser South, Sharp, and Western Health Advantage. When we look at the national 90th percentile, we look at the top performers in the country, we could see again that Blues in various parts of the country, Blue Cross and Blue Shield of Massachusetts, as well as Anthem, Blue Cross, Blue Shield in Wisconsin, achieve much higher performance compared to the Blues in our state. Really pretty remarkable, almost a 15 to 20 point difference in blood pressure control among diabetics. When we go to A1C control less than 8, we could see that there's also opportunity for improvement. California, this spread of these measures are more tight, as you can see. 67% for grade A performance nationally, and 63% are under control in California. So we could see here Kaiser falls out, Southern California falls towards the middle of performance in California, with Sharp Health Plan, Northern California, Kaiser, HealthNet, and Blue Shield being at the top. As I mentioned here, the spread is much tighter than in other measures. We also see national top 10 that Sharp is the only health plan in California achieving A1C control for diabetics in the top 10. In terms of poor blood sugar control, you could see that California has a higher proportion of diabetic patients with greater than 9% HbA1c. And we see the same kind of pattern, the Sharps, the Kaisers, and HealthNet and Blue Cross actually are towards, so smaller is better in this measure, a smaller proportion of diabetic patients with above 9. As you can see here again, Sharp Health Plan is the California plan that achieves national top 10, and no other California groups are represented here. Moving on to persistence of beta blocker treatment after a heart attack, we see here very high performance for grade A performance nationally at 92%. California is behind, was 10 points, 80% or 81% here. We see California, Kaiser North and South, again ahead of the curve, both at or above the 90th percentile for the nation. And we could see other plans really below this California average, including United, Cigna, Western Health Advantage, Blue Cross, Sharp, etc. Sharp, not available data. In terms of the national top 10, we don't see any California groups exceeding this, although pointing out the scores are really compressed in the top performance on this measure, making it much more difficult to achieve that level of performance. In terms of testing, this is just did you get an A1C test, sort of the process measure here. We could see that California does fairly well, and most plans are compressed above 85% of patients. But again, you do see Kaiser, both North and South, as well as Sharp, performing above the 90th cut point. In terms of the national 10, one thing to note is that Aetna Health in Maine actually achieved the top performance score in the country, and we see here Aetna, California is at 84%, the worst in our market. And so this is a real disconnect. The same national corporation has the high performance, but also the lowest performance in our state. The highest performance nationally in one market, and the lowest performance in the market. So medical attention for nephropathy, grade A performance at 94, California's at 91, as you can see. Topped out measure, very high performance across the board. Most plans are above 90% performance. We do have some standout national plans that nationally they're doing very well in other markets, but not so well in California. These are pretty compressed and tight performance, though, at the top. For eye exams, it's a really diverse story here. As you can see, the range really differs in our state, from Southern California having a high of 81% of diabetic patients with regular eye exams, to Aetna of California with only 33% of patients receiving eye exam. And We have the middle point about here at 50% with Cigna and Western Health Advantage. So California is pretty behind on this measure, might be because of documentation, challenging with specialty access to these referrals, etc. But it's clear that even in spite of California's relatively low performance, other plans nationally are able to achieve top performance on this measure. Wanted to just highlight the progress that we've made over the years. As Hetty mentioned, the launch of the Right Care initiative really was associated with several grants to try to establish learning communities where best practices around medication management of diabetics to reduce cardiovascular risks were emphasized. And it's really, just before starting, it's really interesting to see nationally how we in California had this collaborative spirit in this project. And as you can see unfolding around the country, a lot of these health reform funded projects do require this collaborative learning community that we've been doing for so long. So if you could look here, what we see is that the national performance, just to point out these bottom slides, the national performance, the 90th percentile is actually improving pretty drastically over time at 5 percentage points for blood pressure control. However, if we see the California average, we're pretty stagnant since about 2008, as well as the national average. So what we see here in the field is the national, there's some plans and groups that are finding their way and able to achieve improved performance, but on the whole, we're still struggling with blood pressure control. We can see again, to point out, here's where you see the Kaisers really making their strides about in the year 2000 and maintaining that high performance over time. This is the patients with diabetes with blood pressure control for the diabetic patients. As you can see here, this is a bit harder. The national 90th percentile, in contrast to the overall population, which improved by 5%. You could see the top performing national 90th percentile actually decreased a little bit over time. And similar story for California, very stagnant performance over time. And the national average on this measure, controlling blood pressure for diabetics, is actually dipping over time. So nationally, this is a really big challenge for all payers. And this is the out-of-range diabetics, and we'll skip that. I wanted to just end with the so what. I think that what we do know is that primary care prevention and medication management of cardiovascular risk among diabetics in particular can really result in lower hospitalizations for acute myocardial infarction and stroke. And just to give you a sense of the burden of these conditions to California payers, you can see here this graph, all charges for our acute myocardial infarction in California. You can see the total here is about $11 billion in the last calendar year. And you can see that Medicare and the Medicare program takes the lion's share, but next in line is really the Medi-Cal program sharing the next biggest slice of the pie in terms of charges. So in terms of the public burden or the public expenditures towards AMI, it's really high here and consequential. Similar stories for stroke, except even more marked in terms of the burden on the public funded health care. As you can see here, the $22 billion last year were as a result of treating hospitalizations due to strokes. And as you can see again in the blue bar, that Medicare is really the dominant payer for these strokes, and followed by other insurances. So really 22 million plus 22 billion plus 11 billion is considerable amounts of public funding that we could otherwise be spending in education, transportation, other things that may have bigger impacts on the social determinants. So wanted to just thank you for your time. I think we have a challenge ahead of us, and I look forward to the collaborative spirit here in this room and in trying to figure out how do we kind of stop the stagnation and actually get some breakthrough improvement here.